Hello.
Hello. Yeah.
Yes, sir. You can start the session.
Yeah. Just 1 minute. I'll start. Okay. Right.
Okay, sir. No problem.
Right. So good evening to all of you. As usual, I will start with a short case first. Is my screen seen? Screen
Yes,
is
sir.
seen. Okay. So this, in fact, 2-3 cases are given by Dr. Joy. This is one of his case. In fact, this girl came with a complaint that she was seeing objects on the right side of the space on the left side, and those objects on the left side of the space were seen on the right side. That is her complaint. And this was followed by headache. I do not know the full story. Only Joy shared this video with me. So I was discussing on that thing. But the etiology may be different. What is important is the symptomatology. For that, I brought this video. Now, this story, if you could understand Malayalam, you can follow that. He's telling that he's telling right side is seen on the left side. Those on the objects on the left side is seen on the right side. That's the thing. So what do you think? So what is the symptom? Anyone?
Visual allesthesia.
Oh, very good. This is called visual allesthesia. Just like our tactile allesthesia where you see in parietal lesion, when you touch one side of the body, it is projected to the other side. Suppose I got right parietal lesion. When you touch the left side, you will feel this touch being, he feels that your ears being touched on the other side, right side. So that is visual allesthesia. So this is tactile allesthesia. This is a visual allesthesia. This is again a parietal lobe symptom, where visual stimuli are transposed from one homonymous field to the other, lesion in the parieto-occipital area. No, I think just because I thought I will show some other complex, interesting visual phenomena for completion's sake. There's nothing pertaining to with nothing to do with this particular case. Now, polyopia is called multiple images, receiving multiple copies of the same object, often arranged in rows and columns. The number of copies is large, more than 100. It is referred to as entomopia. Entomopia is because the eyes which is seen in the insects. True and false images are, unlike the diplopia, here the true and false images are all equal, are clear. There's not a blurred image here. Polyopia precipitated by ocular fixation is often precipitated by ocular fixation movement of the object. It can be associated with palinopsia. I'll tell you what palinopsia is later on. The polyopia is due to dysfunction within the parietal lobe coordinate systems. This is a classical one of the picture of polyopia where he feeds multiple images of his upper limb. Now, palinopsia, on the other hand, on the other side, on the other hand, is the continuation of the visual sensation after cessation of the stimulus. If the stimulus is taken away, still you continue to perceive the previously perceived, continue to see previously perceived images. Or it can be an episodic, intermittent reappearance of images without immediate visual stimulation. That can appear sometime late to the same image which is earlier, come back again. The physiology is due to parieto-occipital lesion, more often on the right side. Under palinopsia, there is different types. One is visual perseveration, delayed palinopsia, illusory visual spread, that is spread of a pattern from an object to the surroundings. Trailing phenomenon, where the visual perseveration in which a series of discontinuous stationary images trail behind a moving object. I'll show the pictures of this thing. It is due to dysfunction within the parietal lobe coordinate systems. Now, what is visual perseveration? It is a positive after image which persists after removal of the object. That is continuous visual sensation after cessation of stimulus. Object remaining fixed in the retinal coordinates with eye movements. Like this is continued to perceive the stimulus even if the stimulus is removed. Delayed allesthesia is one in which the object is already disappeared, is seeing some other objects instead, but the previous image coming back into the field of view after some time. That is episodic, intermittent reappearance of images without immediate visual stimulation. That is object returning to the field of view. This again due to the paradoxical relation more often on the right side. Then illusory visual spread is the spread of the pattern from an object to the surroundings. And the place where it is go to the surrounding area, the image will spread. And trailing phenomenon is a type of visual perseveration in which a series of discontinuous stationary images trail behind a moving object. It describes an object in motion, leaving frozen copies in its wake. For example, if you're moving a banana like this, that copy, the image of the banana, we can be seen trailing behind. If you move your hand like that, you can see multiple hands behind that behind your hand. That is visual perseveration in which a series of discontinuous stationary images trail behind a moving object. Visual synthesia is visual images are produced by auditory or gustatory stimuli. Can occur with lesions in all parts of the visual pathway. That is, other stimuli produces a visual scene. Suppose you smell something, instead of the smell you hear, some vision, some abnormality in the vision will occur. So you will see some visual images. Visual dysesthesia is that unpleasant visual sensation when looking into an area of visual loss. This is seen in lesions of the optic radiation. The another interesting phenomenon is Akinetopsia, where it's a loss of motion perception. It's an acquired defect of motion perception. Patients to report that they see movement of most objects in a freeze frame manner like slow motion video. It's like they are not seeing a continuous motion, but see is in a discontinuous pattern like that. So if you want to pour a cup of tea onto the cup, pour a cup tea on a cup bottle happen mean she will not be knowing whether the cup is being filled or when the cup is getting filled or not. So patient experience difficulty perceiving the movement in all three dimensions. When attempt to fill a cup, the patient may note that the fluid appears to be frozen like a glacier and does not know when to stop pouring because he cannot appreciate the change in the fluid level in the cup until it is too late. So she does not know that that level is rising up, but after some time it has already been overflowed. See this video, the patient is seeing a dog running towards you. The people and animals may seem suddenly appear at different places in the visual field. Look at this video. The dog is coming towards you. This is how they perceive. They will not see the motion continue, only an interrupted images. That is the Akinetopsia. This is due to the disconnection between the spatial coordinate processing in the parietal lobe and the cortical areas concerned with the motion perception. The area for the motion perception is the area 5. The area in the mesial temporal area called area 5 detects the direction speed of the moving objects. There is a dorsomedial cortex. Area 5 gets activated by visual stimuli associated with self-motion and helps guide reaching and other visually guided movements. It can also be unilateral. In one sided lesion can produce loss of motion perception of the contralateral field alone. And this is the area concerned, that area V5, that is the medial temporal area. So I think I'll skip the other things and all. So that's all regarding the first case. Then I'll go to the proper second case. Any questions? I just brought because that's the interesting symptom of the patient, which is not often heard of. That is why I brought that particular patient. Okay, shall I go to the next case?
This is a migraine aura, sir, the patient.
I think it's much migraine aura. Only Joy will know whether it's a seizure phenomena or a migraine. But only I brought it just because of the symptom only.
Which side of this is a parietal? Which side, right?
Here it was seen, she's telling shifting from one side to the other. It can occur most commonly on the right-sided parietal lesions. Just like Williams allesthesia, tactile allesthesia. More often seen on the right-sided lesions. Okay, shall I go to the next case?
Sir.
Okay, this is a quite long case, difficult to decipher out. These two videos are given, one by Dr. Joy, the other by Dr. Parameswaran. Both are very intriguing cases. Now, Joy, as usual, is a very fast. His video is also very fast. I will show you in the slow motion also. Try to decipher out what his problem is. I don't know the symptom of the patient. Probably some visual blurring or some other, he has come with some other problem, but this is the eye movement which has been sent. Let us ask him to look to the right side. Looking up, looking left and down, right and down, again left and down. Okay, what do you think about too confusing? No, it is too fast. So to make it easier, I will show it in slow motion. That will be easy for you. So the same thing I am trying to show in slow motion. It's asking me to look to the right side, then to the left side, up, left, down, again up and right and down, left and down, straight, up, straight, left, left and down, right and down. Okay. Any idea about what this ocular movement could be?
The geotropic gaze deviation.
No, it's not geotropic gaze deviation. It's a little different one.
Whenever the patient is trying to look on either side, there is a vertical disconjugation that is apparent.
Correct. Vertical disconjugation is apparent. Correct. Only I'll show the what do you call screenshot of each section. Then it will be easy to understand. Let's find out what it is crossing. In a geotropical gaze deviation, it's actually a little different. When you turn to one direction, turn the head to one direction, the eyes will both will actually go to that. Gaze will deviate to that side. That is geotropic gaze deviation. Not that this is only confined to one eye. There's a disconjugation of movement here. It's not parallelism. In the gaze means eye movements are all parallel. About that, it'll come later. Let us say I will show the freeze frames, the screenshots in various eye positions. This is the primary position. Okay. Here, this is patient is asked to look to the right side. As you can find that right eye is a little out compared to the left, and the left eye is slightly down, or right eye is slightly up. Okay, this is on looking to the right side. Okay. Now this is looking to the left side. Here again, you find that left eye is moving much more than the right eye. That means right eye is exotropic again. If the right eye is slightly low, left eye is slightly up. Now looking up, there is both eyes are moving up, but right eye is exotropic, it's gone outward a little bit. Looking down again, the eye has gone out on the right side. Left eye is, say, looking down. Again, this is one time he is looking down. That time again, both eyes has looked down again. Sometimes he's looking down like this. Okay? In both, this is the eye movement. In both the times, he has to look down. Now he's looking down and to the right. The right eye is up, left eye is much down. So what does it indicate? Maybe indicate that it can be either hypertrophy of the right eye or a hypertrophy of the left eye. If the right eye is up, what will happen? It can be weakness of the right superior rectus or Hypertrophy of the left eye means weakness of the left inferior oblique. Either is possible. Or it could be a left superior oblique overaction. That means when it is to the right side, the eye superior oblique is overacting on the left eye. That is why the eye is going down. So these are the various possibilities with this eye position. Now let us look to the left side now. Here there is hypertrophy of the left eye. They may be due to the weakness of the left inferior rectus, or the right eye is down. That means weakness of the right inferior oblique. Or again, it can be a right superior oblique overaction. Okay, these are the possibilities. So any thoughts now? I told you it's not a simple case. So what is your impression? If you want, I'll show the pictures again if you want. This is primary position. Look into the right side, left side, looking up, looking down, again looking down onto the right, looking down onto the left. Any thoughts?
Sir, alternating skew.
No, it's not. Okay, you can call it that alternating skew, agreed. But is it present only the skew is there? It's got a horizontal separation of the eye is also there.
Yes, sir.
Okay. See this one?
His vision normal, sir?
Pardon?
His vision is normal?
Vision is normal. Visual acuity of each eye is normal. No, to analyze this thing, what do you find actually? It's got some but the first step is it's got disconjugation. Okay? The eyes are not parallel. Full stop. Okay. We do not know why the eyes are not parallel. It can be due to what? Paralysis of one of the extraocular muscle is the commonest thing cause of non-parallelism. Or as you said, a skew deviation. That's a possibility, but it's not a skew deviation here. And if you skew deviation multiple levels, the eyes are in different levels. For example, if this is looking down, at other time, this is looking down here. This is also both looking down. So what does it mean? It can be either due to the weakness of one of the extraocular muscles or due to a concomitant squint. Concomitant squint means malalignment of the eyes. Okay. He is fixing me because of the malalignment due to congenital problem or a concomitant squint. What happened means that he'll be fixing only with one eye. He will not be fixing with the other eye. One eye is a good eye, the other is a lazy eye. And the laziness in the eye can shift from one eye to the another, depending upon which you want to fix down. Okay. Now, what will you test will you do differentiate is actually concomitant squint or a paralytic squint?
Cover, uncover.
Okay, cover,
Duction,
uncover.
duction.
Duction movement. Cover and will come that one will come to that later. But to do duction movement. So duction movement, what will happen? If it's a concomitant squint, there will not be a restriction in any direction. The full range of ocular movement in either way goes one eye. So let us see the duction movement. So let us say duction testing. So I'm closing the right eye.
വലത്തോട്ട് നോക്കൂ, ഇടത്തോട്ട് നോക്കൂ, മുകളിലേക്ക് നോക്കൂ, താഴേക്ക് നോക്കൂ, താഴേക്കും വലത്തോട്ടായിട്ട് നോക്കൂ,
Right and down,
ഇടത്തോട്ടും താഴോട്ടായിട്ട് നോക്കൂ,
left and down, right eye, medially, laterally,
താഴേക്ക് നോക്കൂ,
up and down, down and out, down and in. So what did you observe?
It very fast but appears normal.
Okay, fast. I'll show it. I'll show it in slow motion. Okay, right. Let us see. I'll show it in slow motion. This is on looking to the right side, looking to the left side, looking up, looking down, up and out, then down and out, up and inside, down and inside, down inside, laterally and down. Okay, now left, right eye, medially, out, then looking up and out, down and out, down and in. Okay, so what did you observe?
Left inferior oblique appears weak, sir.
No, it's what do you mean? Almost all I think the things almost all normal. I said normal,
Yes, sir.
normal range. Okay,
Yeah, sir.
you couldn't make out a gross restriction of movement. Okay, almost normal. So adduction movements are normal. See, when you found the other one, when you the previous during the version movement, there was a gross disconjugation. One eye is not moving at all, or much more moving down. That is not seen here. Okay, even the so-called paralyzed eye is also moving well now. That means it is not a paralytic squint. I'll show you one example. So, for example, if you the other picture which is shown here, let us see this one. The right eye appears not moving down on here, like right inferior rectus. But when you do the adduction, it appears the right inferior rectus is weak here. Okay. When you do the adduction movement, I'll show the picture now. See, it is moving very well down. Okay. You understood? That means it is not due to the paralysis of the muscles. The eye which was not moving down earlier is not moving with eye closed. So I'll show the screenshots of each one. This is in a video I shown. The eye movement by closing each eye. Now closing left eye now. Again, full range of movement, adduction, abduction, elevation, depression, also very good depression. This is also very good depression in the adducted position, correct? Now I'll show the screenshots. This is adduction of the left eye, or looking after closing the right eye, looking to the right side. Adduction is good. Abduction is good. Left eye. Elevation is okay. Depression is good. Inside out, down and out is also good. Adduction of the right eye. Adduction is normal. Abduction is okay. Elevation, depression. Depression in down and out. So, what do you think? What is the problem with this patient? It's a concomitant squint, non-paralytic squint. Yeah, it is present from early life due to the misalignment of the eye muscles. Okay. Any difficulty in understanding? I'll answer the question. Okay, it's not a paralytic squint, it's a concomitant squint. Okay, which eye is, now the question is, which eye is lazy, right side or left side? Which is a good eye, which is a bad eye here? So for that, what test will you do?
Oh, in
Cover
extreme
uncover.
case, we do cover uncover.
Very good, very good. Extreme circuit Rukanga. That's the thing you have to do. Now let us see the let us see now the cover uncover.
മുകളിലേക്ക് നോക്കൂ ഇനി അടുത്തോട്ട് താഴോട്ടായിട്ട് ഇതാണ് അടുത്ത വശം അവിടെ താഴോട്ടായിട്ട് നോക്കൂ അവിടെ താഴോട്ടായിട്ട് നോക്കൂ താഴേക്ക് നോക്കൂ താഴോട്ടായിട്ട് നോക്കൂ
You get very fast, that's difficult to find out. I'll show the slow motion, that'll be better. Now in slow motion, covering on each eye and looking at the cover uncover test. Now see what has happened to the right eye now. It's coming back and fixing up now. Now he's closing the left eye. Then he's closing the right eye and asked to fix with the left eye. Closing the right eye now. The right eye is deviating, coming back and fixing it. Okay, I will show you once again. Now he's looking with the left eye. Under cover, what has happened to the right eye has gone out. Now he's coming to fix it up. Now he's closing the left eye. Okay, he's viewing with the right eye. Then the closing, and look at what happened to the left eye. The left eye, which has already been deviated under cover, is coming back. Then remove the cover, what happens, see once again. I'll show you once again. See, what you have to observe is that what had happened to the eye under cover. Okay, it must have deviated, gone to the lazy position. When you look bilaterally, when binocularly, you're trying to fix with both eyes. Okay, one is a good eye, one is a lazy eye. When you cover one eye, what will happen? The lazy eye will go deviate its original lazy position. You remove the cover, you will try to fix up onto the object. So I will show the video once again now. Now, he is looking to the left side now. Okay, his left eye is focusing onto the object. Now, the right eye, if it's an alignment, you would have been again looking to the same direction. So what would happen means that on removing, see what happened? The eye has already been deviated out. It has gone. This is the lazy position of the right eye. So it has to look to the left side, he comes back, the eye right goes back and fixes onto the left side. You got the understand? The same thing I'm showing again. See, that's what happened. He comes and fixes it again to the left side because he's asked to look to the left and down. Okay, so that means the right eye is now lazy. Okay, now let us go to the further example. Now going to the sorry. Now I'm so. I think this is very good. Now this is a position now. Now I'm going to follow. See, he is fixing with the right eye now. If his left eye is lazy, that will deviated outward or wherever he goes. Let us see. Now on opening, what happened to the left eye? See, it is already deviated out. Now he's coming back and fixing it up. Under cover of the left eye, under cover of the left eye, the eye had already gone outward. Okay, now he's trying to fix it up. So what is happening here? There is no dominant eye here. Both eyes are lazy. And this is what is called
Alternating fixator.
Perfect. Alternating fixator. That means you can switch from one other to another eye. This often is a good mechanism to prevent amblyopia developing. If one eye is persistently lazy, he is not made to work with that lazy eye, that eye will become blind. So that the patient will try to fixate with either eye, with either eye at different times, not consistently with one eye. So this is called the alternate fixate. So under closed eye, yeah, please.
Sir, in this, the test being done is alternate cover, right? Because he is not made to look at the object with both eyes simultaneously.
Correct. Correct. Then what idea is what our idea is to that he should not, he is allowed to fix only with one eye and let the other eye go into his lazy position.
But when we are doing it this way, he will anyway have to fix with the other eye. If you are closing with the other one eye and asking him to focus, he will have to fix with the other.
I'll tell you. Suppose you have got an orthotropic eye. Both eyes are the same alignment. What will happen? Same alignment. Even if you close the other eye will be in the same position.
Yes, sir.
Here, either what happening is that when you close the right eye, see, when you look with both eyes are looking in the same direction. Okay, looking down and out. When we close eye, the right eye is being lazy. It has gone on to its own original lazy position. Left eye has to fix. Now, when I close my left eye, I have to look at the object. The lazy has to come back again to the position and look at the object. So that means this eye has been deviated under cover.
Yes, sir.
That is the idea.
Okay. Okay, sir.
Yeah,
Yeah, but,
please.
yeah, but we would ideally want to do a cover uncover test, right? This is an alternate cover test.
What he said is correct. But in fact, the cover uncover should have been ideal. But this, if you do an alternate cover also, it has got the same value as the cover uncover test. Because only thing is that in the cover uncover test, what you're observing is the uncovered eye is being looked at. Okay. Here we are looking at the deviation under cover, and we are taking the usefulness of the redress, movement of the redress, the coming back of the eye to detect that the eye is deviated or not.
Okay, sir. Okay, sir. Thank you.
What is correct? Ideally, it should have been a cover uncover test. Then only to go for an alternate cover test.
So can this movement be called a saccadic ipsipulsion, or is it different?
No, saccadic ipsipulsion is different. Here, saccadic ipsipulsion is in a saccade, when the both eyes will be deviated to one direction under cover.
Okay.
Here, there is a disconjugation. Only one eye is deviated. One eye is lazy.
Okay.
See, concomitant squint means what? Non-parallelism. One eye is straight, one eye is deviated. The deviation may be due to paralysis or due to the paralytic squint, or can be non-paralytic squint, otherwise called the concomitant squint or a comitant squint. In non-paralytic squint means what? That means that disconjugation is same in all directions. In whichever direction you look, that disconjugation will be there. That is a concomitant squint. But in the case of paralytic squint, only in one direction, suppose lateral rectus is weak, the disconjugation is only looking to the right side, not present to the left side. That is why normally we differentiate a concomitant squint from a paralytic squint. You understood that thing?
Yes, sir.
Then we put a duction movement. Duction movement, when you close eyes, the movements will be all normal. The non-parallelism will not be evident because the patient is able to look, in all range of movement will be normal. But if you look both in concomitant squint, suppose you deviated like that deviation will be maintained in all directions. Okay, right? So when you look to the right side, it appears that left medial rectus is weak. But when you close right eye, this will move. This will be, the right eye will be moving a little more out. Okay. In the case of paralytic, in that direction, disconjugation will be there. In other direction, it will not be there. There is more complicated.
Is this phenomena called the spread of comitants?
No, the spread of competence is different. The spread of competence is what happens in a paralytic squint. Ultimately, it becomes like a concomitant squint. That means, suppose you know what will happen. In paralytic squint, as told before, the disconjugation, the difference in the position will be only in one direction. Suppose my lateral rectus is weak, means left eye is straight, lateral rectus is adducted. Okay. That will be manifest only on looking to the right side. On looking to the left side, that is not there. The difference is not there. Okay. Both are working normally. Looking up also okay. Only on looking to the right side, the disconjugation will appear in lateral rectus. Spread of comitants mean in chronic paralytic squint, what will happen? That difference, that separation become equal in all directions.
Okay, sir.
That is called a spread of comitants. That to understand, it is difficult to understand. That another class I will tell you what happened mean. This is something called according to the Hering law of equal innovation. Suppose I want to look to the right side. Right lateral rectus is paralyzed. Okay. So what like for looking to the right side, right lateral rectus paralysis means that it's put more effort onto the right lateral rectus. Okay. Now I want to look to the left side. The left side, what happened? The right medial rectus needs only less innervation because already the right lateral rectus is paralyzed. So it is easy for the medial rectus to move inside. I'll explain it once again. Suppose imagine I got right lateral rectus is paralyzed. My right lateral rectus is paralyzed. So looking to the right side, my lateral rectus is weak. Okay. The left lateral rectus is normally attacking. Okay. Now I want to the left side. So what happened for the left side, what will happen? The right medial rectus should contract, left lateral rectus contract. Left is normal, so it's contracting. For the medial rectus to adduct, it does not require the same innervation as the left lateral rectus. Because already that medial rectus is an abduction is lost. Already it is adducted. Because there is no antagonistic contraction. So lateral rectus is weak means the right medial rectus is already in the adducted position. It less innervation to adduct to the position. For example, I want 10 impulses for my left lateral rectus and 10 impulses for the right medial rectus to deviate to the left side. When my right lateral rectus is weak, that right medial rectus need only 8 innervation. Because it's not already the antagonistic pull is not there. So it's already the eye is adducted because the lateral rectus is weak. So I need only less innervation. So this over time will be translated into all of the muscles, especially in the vertical muscles. So there is circularly all then it will go to the other eye, that it becomes a spread of competence will occur. A vertical deviation will be equal in all directions of case.
Okay.
And this is the mechanism of inhibitional palsy in lateral rectus weakness. The spread of competence usually is seen in vertical recti muscles or oblique recti muscle weakness. The same thing, the antagonistic muscle, suppose superior rectus is weak. My left inferior rectus is an advantage because it's easy to look up. The other way, look the other side. So this will go around and round and become a spread of competence. Okay, now here under closed eye, that eye goes into a lazy position. When you close the other eye, the lazy eye takes a fixation, which I've already seen. The same thing occurs when the other eye is covered. Now I'll show you another phenomena. On looking down, why this is so? Here on the upper part, the left, it seems the left eye is looking at the object, right eye is deviated. On the second one below, the right eye is looking, left eye is deviated. What is it due to? Same thing. Here, on the upper part, he is fixing the right eye, the left eye. He is neglecting the right. On the lower part, he is fixing the right eye, neglecting the left. That again shows you net fixated. Okay. After some time, he fixes the other eye also. That is why in the previous picture which was shown, the eyes are different in different times. This is called alternate fixated. Now see these two screenshots. See, what did you observe here? Eyes look parallel. On looking down, the left eye has gone out. But that is not the usual situation, concomitant squint. The separation should be maintained throughout, wherever direction is look. Therefore, there is no paralysis. But it seems here, it looks as gone out. The disconjugation varies with the position of the eyes in up and down position. This is called the A pattern. A pattern means looking up, it becomes closer. Looking down, it diverges out. The other way around also can occur. Looking up, the eyes will diverge out. Looking down, that's called the V pattern. Now, this phenomena has also been described in concomitant squint or congenital squint. In the normal concomitant squint, you expect the deviation should be same in all directions, as told before, unlike in a paralytic squint. But some degree of this kind of a disconjugation can occur in the up and down position. This is called AV patterns of strabismus. Described horizontal strabismus is characterized by a substantial change in the horizontal deviation from the midline position in up gaze as compared to down gaze. Approximately 25 to 50% of strabismus patients have A or B patterns. A pattern is present when the horizontal deviation is more convergent alignment up gaze and more divergent on down gaze, just like A. The V pattern gives a horizontal deviation that's more convergent, less divergent in down gaze compared to the up gaze. I will become divergent upward, looking up, and converge looking down. That is a V pattern. This is relatively frequent patient in infinite onset strabismus, and the mechanism is very difficult. I have not. So this is the V. This is the A pattern. Looking down, the eyes diverge. Now look at the picture once again. Looking down, and to the right side here, the left eye is down, right eye is up. Here, the right eye is down, left eye is up. Okay, because we told that he is fixing with the other eye. Question now: why can't we left superior oblique overaction here on the here? And why can't be right superior oblique action? There is a condition, two other conditions called the oblique overaction and the other condition called Brown syndrome. See look at the left picture here on the left side, down, and to the right picture on the left side here. If when the right eye is laterally, left eye is down and deviate inside, that can occur due to some other condition that's called superior oblique overaction. Suppose looking to the right side, left superior oblique may overact and bring the eye downward like this. Okay. Same thing here on the left picture onto the left side, looking down onto the left. The right eye seems to be looking much more down than the left eye. That means again, the right superior oblique on the left picture here is overacting. This is called superior oblique overaction. Sometimes can be bilaterals. So why can't we in the particular patient, our patient had this one? That is what Joy asked me this thing in his thing. The other condition which can put in this configuration is Brown syndrome. What is Brown syndrome? Because of the Brown syndrome is a condition where the tenosynovitis superior oblique tendon. There's a restrictive ophthalmopathy where the patient on the adducted position, the eye cannot, and superior oblique will not act. That means it will prevent the inferior oblique to produce elevation. Because to produce inferior oblique to produce this elevation, the superior oblique has to relax. The antagonistic must relax. That will not occur because of the restrictive ophthalmopathy. Anyway, this is superior oblique overaction and or bilateral Brown syndrome. These are the two DD you have to keep in mind. Why not bilateral Brown syndrome? Any idea why can be Brown syndrome? Brown syndrome means look in the adducted position, the eye will go down. I will go down like this. Because in the adducted position, the superior oblique tendon is short. So the eye will come down. Now look at this video now. See the adduction that this will not, it cannot occur this is not a Brown syndrome because in Down syndrome, in Brown syndrome, there is a restriction be there whether he close one eye or not. Here on duction testing, the movement is normal. The adducted position looking up, there is normal elevation on the adducted position. That means there is no Brown syndrome at all. There is no restriction of movement of the ocular movements. So it cannot be Down syndrome. There is no depression of the right eye on looking medially. See, initially, if I find that the right eye is looking down, looking medially, but that is not there when you close one eye. That shows what? It is not a restrictive ophthalmopathy. If it had been a Brown syndrome, even with the closing eye, the eye should have been down on looking medially because of the restriction of the superior oblique. So the inferior oblique cannot act. The superior oblique is not relaxing, so inferior oblique cannot act.
Yes, sir.
Okay. Then so can be bilateral Brown syndrome. The reductions are affected in Brown syndrome. That's the reason. The deviation directing will be seen even during reduction movement. That is, when you close one eye or not, the upward restriction directive will be present in Brown syndrome. Look at this particular girl's video. This is a case of Brown. What is happening to the left side? The right eye goes down. And on looking up, the right eye is not. This is classical Brown syndrome. Looking up, the right eye. Looking up, right eye is not moving up because there is inferior oblique is prevented from elevating the eye because superior oblique is prevented. The superior oblique is not relaxing. That is a classical. That's not what you observed in our patient. Actually, you should have closed one eye to find out whether the eye is moving up or not. This is a Brown syndrome. Up and out is okay. That's okay. Up and inside is on that is effective. Again, adducted person looking at. See, adducted person you cannot look up. Abducted person you can look up. Adducted person patient is not at all looking up. That means either inferior oblique is not acting or it is prevented from superior oblique. Now, why not that in this particular patient? Now, the other question is, why not superior oblique overaction, which I mentioned? This is again not superior oblique overaction because in a superior oblique overaction, that problem occurs only when the patient is put in the superior oblique is put into the action. That is only down and out. Here under cover, the eye deviates. That means it's not a superior oblique overaction. So in slow motion, what will happen? The video is shown again. See, the eye is already deviated. If it is superior oblique overaction, that will not occur. Under cover, the eye should not deviate. That means the eye is lazy here. And that is why this apparent overaction is not due to the superior oblique overaction.
Sir, one more time, please. This one.
This one. The
Why
last
not
one, no?
superior oblique overaction, sir? Yes, sir.
I'll tell you. In superior oblique, I'll show the picture once again. Now here, let us see this picture. See, patient is on the left picture, looking down onto the right, which is shown here. The right eye is up, left eye is down, correct? So that can be due to the left eye superior oblique overaction, correct? Here also, here onto the picture onto the right side, patient looking to the left side, the right eye is down. That also can be due to right superior oblique overaction.
Yes.
Correct? Right.
Yes, sir.
Yeah, that's we have to differentiate that from a concomitant squint or lazy eye. If suppose imagine that this patient has got a superior, let's take this picture on the left side. Left eye is overacting, superior is overacting. Now what will happen means, if you cover one eye also, that eye should be looking in the same direction. Or it will be in the primary looking medially. It should not show laterally.
Okay.
See here, we're looking at the right side. When you cover left eye, the left eye may be in the same position or it may be up on the adducted position. It's not maybe overacting, maybe but there is no reason why you should go laterally.
Okay, sir.
Okay. Now let us see the picture now. Now let us see the slow motion. Under cover, the eye deviate. See, the eye is closed. Now the right eye is gone out. Now it's coming back. In a superior oblique, why should it go out? Now it was the right eye. Left eye is gone out now. And is coming up and fixing it up. Okay.
Okay.
So that means that the eye under cover has gone on its own way. Its own path it has taken. It has gone on its lazy position. That will not be seen in superior oblique overaction. Patients are asked to look into the direction, same direction. Whether close eye also, that eye should be there only. I should go move out under cover. Is it understood?
Yes, sir.
So this is not a simple case. So under closed eye, the eye goes in a lazy position. When you close the other eye, the lazy position takes a fixation. This will not occur with the superior oblique overaction. Occurs when it is put into action. Okay. I think I will skip this one. On syndrome at all. Tenosynovitis. This is how differentiate between all the things. I will skip this slide. So any question? Is it a tough case? Any questions? Any point which you have not understood, please ask me. Because many times people will come to you with this complaint of so-called squint or diplopia, and then this problem will come, whether it's a manifestation squint or not.
Sir, in case of superior or inferior oblique overaction, can we check the torsional movements, intorsion or extorsion, to find out whether it is due to that? Because it is superior obliques will extort, will intort.
Definitely, it can find out. You can look for that. The only thing is that we are only seeing the terminal position. The rotation movement, we cannot make it out. When you're looking down, at that time, if you can, okay, you can look for that. If your overaction is there, there will be an intorsion movement. But at the end position, you cannot see whether eye is rotated, intorted, or extorted. For that, you should know the previous position of the vessels on the sclera. That you can do during movement. That can look.
Sir, Brown syndrome, is it surgically correctable?
Yeah, it is surgically correctable. Because actually it's a tenosynovitis on the trochlea, so that is preventing the superior oblique from relaxing. Only if it relaxes, the inferior oblique can produce the elevation. So that can be corrected.
Sir, in case of this alternating fixator, do we prescribe prism glasses or do we ask the patient to cover one eye?
Okay, actually, if it is only mild squint, there is called a prism glass is there. I can show the prism glass. If it's they measure the deviation in terms of diopters. So beyond one certain degree of diopters, your prism glass cannot work. In that case, you have to undergo surgery. If it's only mild degree of squint, the prism glass can correct it. Some degrees is there, I don't know. More than 10 diopters or so they say you have to undergo surgery. Okay, I will show you. See, I think this is. If you're interested, if you want to know about the cover, uncover test, I can tell that. Otherwise, I'll skip this particular portion. What is the role of cover, uncover, and alternate cover test? I think I'll go to the other thing. I'll skip this one. Okay, this is case for Dr. Parameswaran. Again, something similar. Look at it very carefully now. Look to the right, left side and right side. Up, down. Look to the left side, the right eye goes up. Right side, left eye goes up in the directed position. Again, same thing. Looking up. Okay, what is the diagnosis? I will show it in slow motion. Once again. Looking to the left and up. Left side, straight left. Straight right, left eye goes up. Left, right eye goes up. Then looking straight up, no problem. Looking down, again, not much of a problem. Looking left, so has to follow the finger to the left, following the finger to the right side. Okay, what is this one?
Sir, to show the adduction.
Okay, right. Adduction, correct. Now I'll show the picture again. This is the one already
This is also
shown.
alternate fixator, sir. Bilateral eyes
Yeah.
are
Alternate fixator. My question now is, why can't be bilateral inferior oblique overaction?
Can be,
It
sir.
can. It can be. That's the question. This can be inferior oblique overaction. But let us see. Now I'll show the adduction movement. Those one eye movements are all normal range. Actually, we should have looked in the up in the adducted position. So from the whatever the available video, it looks that the eye movements are normal. So what does it tell you? It's not a pediatric squint. Okay, that much is certain. So it can be concomitant squint, just like the previous patient, alternate fixator. What else is possible? It can be an inferior oblique overaction. Okay, so for that, what you should have done, just like we did before,
cover test, cover and uncover test.
To find out whether under cover that goes into this lazy position. In this particular girl, on asking the patient, look to the right side, cover the left eye, ask the patient, look to the right side. Under the cover, you see whether the eye has gone up. The lazy position has gone up. How do you know that? Remove the cover, the eye will come back, just like the previous one. Or you can, under cover, you can, behind that cover, you can go and see the eye position. That also they can do. Or remove the cover, the eye will come back. That is indirect evidence that the eye has already been shifted under cover. Otherwise, here in this patient, the possibility of an inferior oblique overaction cannot be totally ruled out.
Sir, here also, when we are covering the eye is going into the lazy position, so it is not an inferior oblique overaction. That is what.
No, it's not going. No. It's not like that. Here, the adduction movements are normal. See, in the oblique overaction, the adduction will be normal. Only in conjugate movement, the oblique overaction will manifest. That is a very complicated mechanism. Then the adduction is normal. So normal, in both concomitant squint adduction is normal, as well as oblique overaction also adduction is normal. But the eye will not go into lazy position in the case of a overaction. Because the other eye will deviate.
Yes, sir, that's what I told. Yes, sir.
Okay, sir, sorry. But here it was not done. That's the thing. The reductions, I think same thing which I have slow motion. But I showed is look at the eye movement. So what is an alternating hypertrophy in that position? Okay, shall I go to the next case?
Yes, sir.
Sir, this this thing occurs only in oblique.
Overaction is usually in the superior oblique overaction or inferior oblique overaction. That's usually
oblique is only with oblique.
Oblique is there. And if you read the mechanism, is very complicated. Why it is? They say some neural connections are abnormal, some other supranuclear mechanisms are all postulate. I'll tell you some of the explanations. I copied it here.
It is always bilateral, sir.
It's bilateral, usually bilateral. It can be unilateral, also it can be bilateral.
Okay, sir. Thank you, sir.
This is a various explanation I showed you there. Anyway, I'll skip that. This is explanation. These are the various hypotheses. This kind of AV pattern as oblique overaction. Abnormal supranuclear circuit, visual hyperfunction, loss of vision, the abnormal torsion. I do not understand what did the meaning. Okay.
What are the symptoms they usually come with, and what can we do for them?
No, usually they don't have any symptoms.
Okay. Just the incidental finding.
Accustomed to that.
Okay.
Okay, I'll go to the next case now. The story of a 70-year-old lady. In fact, she was underwent treatment for early dementia for the last 1 year. She was presently brought with the complaint that she was speaking to her image in the mirror, sometime quarreling with it for the last 1 month. This is for the last 1 month. So this is the patient. I'm asking who that person is. Telling she's a sister. This is the video I'll show once again. This is a sister. Ask her to talk to her sister. Ask her, what is the name of her sister? She's still some other name. Then the country is telling there is no sister for her. He said, who else is that? It's not a sister. Have you? She said, not telling it is a daughter. Again, same name. Ask you to talk to the person. He's asking, he's talking to the person. He's asking. He's asking the name of the person. Where are you staying? He's telling that the other person also staying nearby. They're staying near the house, near a house. I think the three part I'll tell you. I asked her who the other person seen in the mirror was. She initially said it was her sister. She had in fact no sister. I asked her name. She said a different name of the person seen in the mirror. Then I told her it was not her sister. Then she said it was her daughter. She said the same name. Then I asked her to speak to the person in front and then started conversing with her. So what is the diagnosis?
Mirror image agnosia.
Very good. This mirror image agnosia, perfectly right. Why not prosopagnosia?
Because in real time, she is identifying others.
Right,
Only
correct. Because only, correct. It's only the problem is when you perceive through the problem is only seeing her own image. Because have you ever seen your image, your picture without any image? Sorry. We have never seen our faces, no? No one has ever seen our face. We have only seen our reflections. From time, other person's face you can see, but our own face we cannot see. We are not seen. We are only seen through reflection. That's the problem here in mirror image agnosia. So before that, you have to rule out prosopagnosia. Because prosopagnosia is also the same thing, but should not be recognized familiar faces. Okay? Because prosopagnosia, the patient in a severe form, patient will not recognize her own face. Severe degree. So what will you do? Show the persons and then find out. So rest of the videos. As rule out object agnosia, she said correctly. She said cell phone. She said correctly. Then I showed Mahatma Gandhi. Gandhi. She said Gandhi. I showed the.
Narendra Modi കണ്ടിട്ടുണ്ടോ? ഓ നരേന്ദ്ര മോദി ആണോ? നോക്കി. Okay.
So she is able to recognize all familiar persons. Only thing is that she could not recognize her own image in the reflection in the mirror. Okay, that is called she has no object agnosia, no prosopagnosia. This is called mirror image agnosia. Mirror image agnosia is different from little mirror agnosia that I will tell later on. What is mirror agnosia? What happens is that the person, when looking at the reflected images of the objects in the mirror, he imagines that the objects are in fact inside the mirror and not outside. For example, suppose there is a mirror inside. I got something in my hand here. Okay, the person thinks that that object is actually inside the mirror. So the patient will go on touching, poke into the mirror and somebody will break the mirror because she's reaching out the object there. So she cannot realize that that's a reflected image. Only the real image is sees inside the mirror. That is a mirror agnosia. When a person cannot recognize his own image in the mirror, it is called a mirror image agnosia. And that agnosia can be highly selective within a mode. Because self-images are different from others, as none has seen one's own image except in reflection. Failure to recognize this image can be labeled as mirror image agnosia or prosopagnosia of the reflected self-image. That is mirror image agnosia. In mirror agnosia is a condition where even though the person knows that he is looking in the mirror, as evidenced by ability to identify the frame and glass of the mirror, he fails to recognize the object that are reflected in the mirror as reflections. Okay, so what will happen? The real problem will come when suppose you have got a rear view mirror there. You are looking at, see when you're driving, you look at the rear view mirror to find out whether the car is coming from behind or not. These people will think that is a reflection that car is coming from front because that idea is not there. Therefore, when asked to localize the object, instead of looking for an original object in that place, he will search for the object into the mirror, resulting in damage to the mirror. Such patients, while driving and looking at the rear view mirror, imagine that vehicle behind to be in front and land themselves into accidents. So this his world becomes locked inside his looking glass. In mirror image, on the other hand, mirror image agnosia is different from mirror agnosia in the sense that every images are identified the real locations. In mirror image agnosia, the objects are real locations. They know that they can look into the rear mirror, no problem. They can know that the object which are holding is here near you only, not inside the mirror. There is no problem in recognizing the images in the rear view mirror or locating vehicles as coming from behind. No difficulty in identifying the reflected images in the inanimate objects like ornaments and dress as reflected images of their own objects and images. But they have specific difficulty in identifying their own reflected images in the mirror and mistake them as strangers, gods, or enemies and behave appropriately. In simple terms, mirror agnosia is patient looks for real objects inside the mirror, not in the real location. Mirror image agnosia patient cannot identify the reflective self-image and talks, fights, and argues the reflected self-image. In fact, Dr. Chandra had shown 2-3 very interesting cases of mirror image agnosia, where we will show a video where the lady was fighting with the other image, arguing and abusing the other image. This chart is from her article. So, any questions?
Sir, mirror agnosia is then a problem in the what pathway, in the where pathway, and mirror image agnosia is in the what pathway?
I do not know. In fact, the mirror agnosia is not what pathway. It's actually the dorsal stream is the problem, where you cannot locate the object real space. That is a problem in the dorsal stream. The mirror image agnosia is the ventral pathway where the patient he cannot recognize the reflected image of the same person. It's difficult to find out the explanation why it is so and all. But one is the dorsal stream, the other is the ventral stream.
Okay, sir.
Dorsal stream is for the location, visual spatial, where exactly the object is located. The ventral stream is for recognition. Okay. Shall we stop or shall we go for one more case?
One more case, sir.
Okay. The story of a 60-year-old female. She is a known case of diabetes and hypertension. She was admitted in March 2020 with history of acute onset of headache, followed by loss of consciousness. Patient was admitted in local hospital and was found to have cerebellar hemorrhage and treated conservatively. This is the CT picture at that time when she was admitted in the hospital. She's got a significant cerebellar hemorrhage with intraventricular extension. So she survived. There is angiogram notion aneurysm. Patient gradually improved over time, almost normally, except for mild imbalance while walking. That was left. She wasn't bothered about it. However, patient had a worsening of her symptoms for the last 3 weeks prior to admission. That is after 1 year of her initial cerebral hemorrhage. She has come with balance while worsening of the balance. She felt more unsteady and took long time to walk. That is her complaint. She noticed dragging of both feet. These are 2 things she has come down. So this is the present video when she is worsening. Let's go gaze evoke nystagmus. Only the important findings. Power was normal. There is incoordination on the left upper limb, mild incoordination on the right upper limb. Mild incoordination, that too very mild, not very gross. The lower limb power etc. was normal. The detail was upper limb normal. Lower limb knee jerks were brisk, markedly brisk lower limb. Ankle jerks a decrease, is a diabetic. Under indefinite. She is able to feel the vibration sense. And this is complex was negative. And this is how she walked. She short steps with the dragging of both feet. And there is some degree of loss of arm swing. Turns around in block. On examination, hymal function normal, cranial nerves, acebroke nystagmus, speech normal, motor system tone normal in the upper limb, spastic or rigid gait, upper limb DTR just elicitable, lower limb both knee jerks are brisk, ankle jerk absent, plantar indefinite bilaterally, sensations normal, gait short step dragging feet with loss of arm swing. So what is responsible for the present worsening for the last 1 month?
So was there any headache or papilledema?
No. No papilledema, no headache. No, it only come with dragging of the feet. I mean, slowness in walking and imbalance. And she says she has to drag the lower limb.
Repeat CT prime, sir.
Pardon?
Repeat neuroimaging.
Okay. That's what we'll do. I'll give you the neuroimaging, but possibilities will you keep in mind. So this is our idea is to think of various theories before coming to showing the investigation. Then only we'll think of So possibilities. One thing we have to copy is already hemorrhage. You would think of hydrocephalus. So secondary hydrocephalus, one of the causes of subarachnoid hemorrhage. So there's a thing, and gait also can mimic frontal gait disorder, except that she has got a little decrease in the arm swing. The nystagmus is also odd, but that could have been due to the old cerebellar lesion. That is what I had thought. Spinal pyramidal lesion is there, the frontal gait disorder, and what is called the nystagmus, maybe also. This is the things we have to keep in mind. So I thought old cerebral lesion is called nystagmus, the other is a frontal gait disorder, possibly an NPH.
Hemosiderin deposition can it cause like this?
Pardon?
Hemosiderin deposition.
Superficial siderosis, correct.
Siderosis, yeah.
Right. So NPH secondary to intraventricular hemorrhage. The odd point is there is loss of arm swing. Then the spasticity, whether it's unrelated or compression, is also kept in mind. Maybe due to unrelated cervical spondylotic because the spasticity is very dominant in the lower. So MRI was
Possible, sir.
Bilateral?
SDH, sir. It can present as Parkinsonism, frontal.
Yes, definitely it can present with Parkinson, mimic a Parkinsonism. Like frontal ligament. One of the causes of frontal disorder is bilateral SDH. There are three common things, most common in PH. Second is bilateral SDH, as you said, and Binswanger's disease. And even frontal lobe tumor sometimes can produce frontal ligament disorder, like a midline Parkinsonism compressing on both sides. These are the common three causes of a frontal ligament disorder. So the MRI was done now. This is MRI. I'll show the one by one. This is a T2. There is not much hydrocephalus at all. This is sagittal cut. Then T1. And this is the flare. Gradient echo, gradient sequence. MR is cervical spine. Because the spasticity that was done, that is normal. Dorsal spine. Because spasticity spine in the lower limb, that was also done. Okay. Now what do you want now?
Superficial siderosis.
Pardon?
Look like the cortex is showing some gradient.
But he has got bilateral spasticity, no?
Maybe
So can it be drug-induced Parkinsonism?
She was not given any drugs for that matter, antipsychotic medication.
Nimodipine
Moreover,
something.
No, it was not given, no. Again, you have to explain the spasticity part of it. And she was not given any drugs for that.
Okay, sir.
So the gradient axial is showing something in the cortex.
Let me see that.
Yeah, this one.
Yeah, that is there. The socket is there on one side.
This one, no, the gradient posterior aspect.
Yeah, but that is there. Will it explain the patient's walking difficulty and all? Bilateral stiffness, spasticity, dragging of the feet. Okay, what are the things you need? So SWI was done. This is SWI. Look very carefully now. Okay. What is the diagnosis now? Didn't you see? See the picture? Yeah, as Mohan says, there's superficial siderosis. See what is happening. That is surrounding the cord, spinal cord. See the siderosis surrounding the cord here. I'll show the other picture also. See this one. See the cord, what is happening surrounding the cord, spinal cord. See how clearly you can make out the hemosiderin pigment there. See all around. These are all pictures showing the hemosiderin pigment. And you can see the phase sequence showing the hypointensity. See, that is the one here. So remember that superficial siderosis can present with a progressive myelopathy. Sometimes the blood may seep down and then the hemosiderin pigment may surround the spinal cord and can present with a myelopathy also. This also you keep in mind. That is why these patients got predominantly a myelopathic presentation of a superficial siderosis.
So she was not having any hearing deficit.
No, he should not have any. Why? Because it is usually we expect to be hearing because there is bleeding inside the siderosis in the basal systems there.
Yes.
Here the come down, the blood has come down, that formed the siderosis around the cord. So
Why
she said,
not
correct.
upper?
Pardon?
It's a
Beg your pardon?
cervical, still why upper limb was
Yeah,
not involved.
yeah, you're right. But the maximum may be in the lower down. Even though the cervical cord is compressed outside, probably the periphery may be affected maximum because of the lamination, extramedullary compression. No? Or there may be siderosis even in the dorsal cord. That part is not in the film here. But we expect to be upper limb involvement, but need not necessarily be so because since the pyramidal tract is the most peripheral, the lamination of the pyramidal tract is the lower limb fibers are most peripheral. Since some compression occurs from outside, sometimes lower limb may be affected first. As you often cervical spondylotic myelopathy also, even the lower limb complaints will be first, upper limb may not be there, only for some sensory symptom. So, include adult onset slowly progressive gait with cerebellar dysarthria and sensory hearing loss. Pause. Clinically, cirrhosis becomes symptomatic only in 15% of the patients with delay between the presumed onset of the bleeding and first symptom varying from 4 months to 37 years. Here it was 1 year. Patient with supported cirrhosis usually presents slowly progressive irreversible cerebellar ataxia, sensorineural hearing loss in 81% of the symptomatic patients. A myelopathic presentation is also recognized in 53% of the patients, but is exceptionally isolated. Involvement is uncommon. Okay, I think I'll skip all these things. This is from the picture again from the literature. So isolated spinal cord compressed syndrome revealing delayed extensive cirrhosis and secondary to cervical intervention. Okay. So any questions?
Treatment will be symptomatic only.
Symptomatic only. And I have been following that patient for the next 1 year. She's remaining the same, not much of a problem. I give anti-spastic spastic drugs.
Sir, should we uptitrate the anti-spasticity drugs or should we add low-dose syndopa in these patients? Is there any role for syndopa?
No role for syndopa, but problem mainly is she has no definite Parkinsonism at all. So you can some hypokinesis in the upper limb is there. I think we can try syndopa also because you would not know the patient is developing a superadded Parkinsonism. The main thing, the spasticity and dragging of the feet is due to the siderosis. Whether the superadded Parkinsonism is a possibility.
Okay. Thank you, sir.
Thank you. Good night. See you
Good
next.
night.
Good night,
Thank
sir.
you, sir. Good night.
Good night, sir. Thank
Thank
you.
you, sir. Good night.
Good night, sir. Good night.
Good night. Good night.
Good night, sir.
Good
Good
night.
night, sir. Thank you.
The ocular movements are really tough, no? Okay. See you next time.